Welcome to Deep Dive Dialogue on From Genomics to Precision Care, transforming rare disease outcomes. Rare diseases affect millions worldwide, yet most lack effective treatments. Genomic advancements are enabling early diagnosis, targeted therapy, and improved outcomes. By integrating next generation sequencing, multi-omics, and data analytics, we can unravel rare diseases complexities, offering hope to patients and driving transformative care tailored to individual needs. To discuss this topic, we have with us Dr. Swasti Paul. Dr. Swasti Paul is an associate consultant at the Institute of Medical Genetics and Genomics, Sir Gangaram Hospital, New Delhi. She completed her training in medical genetics at the same institution and has since been actively involved in clinical and laboratory genetics. Her work focuses on interpreting next generation sequencing data to provide insights into complex genetic disorders. Her area of interest include neurogenetics, particularly neurodegenerative disorders, fetal malformations, and metabolic genetics. With a strong foundation in clinical genetics and research, she is dedicated to advancing precision medicine and improving outcomes for patients with rare genetic conditions. Welcome, Dr. Swasti.
Thank you, Dr. Manisha. It's a pleasure to be here.
So, to start with, I would like to ask you, as we explore the intersection of genomics and precision care, how do you see the role of genomic diagnostics transforming the landscape of rare disease management in India?
So, till now, rare diseases have kind of been out of the limelight and out of the importance of not just the public eye, but also the authorities. And now, suddenly, there is a lot of awareness about rare diseases. There are different organizations and patient groups that are working a lot for it. So, I must say that I acknowledge how much advancement has really happened. The other major milestone that has happened is genomic testing. So, with the advent of these technologies being available, suddenly we see that more and more people are coming forward for testing. And earlier, a lot of them used to either avoid it or just not find the importance or relevance because they felt that even if they got an answer, it wouldn't lead to anything.
Yeah.
So the new therapeutic revolution has completely transformed that. We are seeing that rare diseases now actually have some curative management that is coming out. And the most important factor is that until you have a genomic diagnosis, that treatment is not applicable to you. So the first step of procuring any kind of medicine or treatment is that you must be aware of your diagnosis or your genetic diagnosis. And I think that's the first intersection of genomic diagnostics and precision care, that it is only going to be applicable when we really utilize the testing resources correctly for the patients so that we can find an answer for them in time, and then the next step is obviously going to be the treatment. So till now we already know that in oncogenetics there is a lot of availability of testing, and then from there on the therapeutics. But even in rare diseases there are many disorders now, the common ones being SMA or DMD, which are, I mean, I should elaborate, spinal muscular atrophy, Duchenne muscular dystrophy, where there is treatment available. And in especially in Duchenne muscular dystrophy, the treatment is tailored to the patient's mutation. So it's very important to understand what is the genomic diagnosis to see are you eligible for therapy or not.
Right. So, as we have seen, that genetic testing is really important and is the key. So, given the diversity of rare diseases and the advancement of genomic technologies, what are the keys of choosing these genetic tests from like their whole genome sequencing, whole exome sequencing, targeted gene panels, chromosomal array, and what are the most commonly used, technique, and how do you determine which one is the appropriate for a particular patient?
So, this is a very good question. So, basically, the different genomic testing is sort of in a structured, in a tiered way, that you can either start with a more basic investigation and then go on to broad based investigations, or you can directly go to what is called a genomic first approach and do the widest test first and then work backwards for the diagnosis. So typically, how we do it is that it has got two main divisions. One is a test which looks at the chromosomes, or the chromosomal based testing, which is the traditional karyotype, and then now we have the microarray. And then the second is which looks at the single gene disorders, or the genomic tests. And in that we have the newer technologies. The older ones like Sanger sequencing and all are already there, and newer ones exome sequencing, genome sequencing, and so on. So as per the guidelines, the typical use of a microarray or a chromosomal test is when you have unexplained intellectual disability with or without any facial dysmorphic features, when you have multiple malformations in a patient, when you have some unexplained phenotypes in a fetus. So in all of these cases, the microarray is the first line of testing, and a microarray typically looks at copy number changes of our chromosomes. That is a small part of a chromosome also, whether it's deleted or duplicated. Typically it catches on from about 10 kb size onwards, up to it can even check for whole chromosomes. The biggest advantage is that it's not a targeted test. It covers the entire chromosomes from 1 to 23, so you can get an answer for any of them even if you weren't particularly sure which one to suspect. So this is a very good test when you're in doubt, and it actually is used as a first line test in many cases. The newer tests that are available are more in play again when you're not exactly sure of the diagnosis. When you know what you're dealing with, like if you have a very specific phenotype that you can see and you are quite sure of the diagnosis, then even something like a Sanger sequencing, which focuses on one gene at a time or a small portion of a gene at a time, is good enough. But nowadays, what is happening is that we're getting more and more disorders, and they mimic each other or they have overlapping features. And typically, in rare disorders, they are so rare that everybody is not even sure of what they're dealing with. So, the broader tests are excellent for those, starting from a panel up to a whole genome. So, in panels, basically, you're limiting the number of genes that you're looking at. And all of these technologies utilize what is called next generation sequencing. In panel, the trade off is that you're looking at lesser number of genes, but you're looking at them at a greater depth. So you're not likely to miss any part of those genes. But the problem is that in case your clinical diagnosis was wrong, or if you weren't sure which gene to include, and it's not there in that panel, then you'll miss the diagnosis because it won't cover that gene. If you're not very sure of your diagnosis, or if the number of genes is too large, then you go for a whole exome sequencing. Typically, for all rare diseases, even at its best, whole exome usually is diagnostic in only about, you can say, 30 to 40% cases, and in very good scenarios, like 50 to 60%. In all other cases, we don't always get a diagnosis. Even in the last level of testing, which is a whole genome sequencing, that covers not only the coding portion of the genes, but it covers the entire genome. There is an incremental yield of only about 10%. So, all in all, actually, in genetic disorders, the diagnostic rate is about 50%. The main advantage with whole genome is you don't know where to focus, you do this test. It also looks at the copy number variants. So if you don't have access to a microarray, then you can look at the single genes and the copy numbers all together. It's the broadest test which covers everything, but the biggest limitation is that the data that comes out of it is so huge that its interpretation is very challenging. So it's not a routine test. So if I was to say finally, what are the routine tests that are used in clinical practice, I think a chromosomal microarray and a clinical or a whole exome sequencing with as much coverage as possible are used most commonly for rare diseases. Yeah.
That's very well said and very well explained. So, my next question is that from the real world, since you're practicing, can you share some example of a rare disease where the diagnosis was possible with the help of genetic testing, and what unique findings were pivotal in solving that case?
So being in the clinic all the time, I of course, if I think about it, I would have so many examples. But yeah, I will share, I think, the case of one of our most challenging children, because not only was it difficult to get the diagnosis, but we actually had to utilize so many technology. This is from maybe 2, 3 years back, where we had a girl, and I obviously won't share any names and identification details. We had a family where they had a young daughter who was very small. She was very short in height. She had a very small head size. She had very little weight gain. For a 5, 6 year old girl, she resembled a 1.5 to 2 year old child. She also was intellectually disabled. She had visual impairment as well. So they were having a lot of difficulty in managing her. And when she came to the clinic, actually, it looked, we were so sure about the clinical diagnosis that we said that, yeah, we know what this is something called Seckle syndrome, or it's something called MOPD, or microcephalic osteodysplastic primordial dwarfs. So primordial dwarfs are basically, they are born very small
Mm.
and they remain small through life. And we sent the whole exome testing,
Mm.
and now that covers all the known genes, and the report we got back had nothing in it.
Oh.
So we were quite baffled, and it took another few months. We reanalyzed the sample. We didn't have an answer. So then we got the parents tested as well.
Mm.
And this time we were now convinced that we're dealing with something different or something new. So we enrolled this family into what was then beginning in India as something called an Indian Undiagnosed Disease Program.
Mm.
And it was running at our hospital as well. And this was linked with the Undiagnosed Disease Network International, and it was specifically built for such rare disorders that the diagnosis is very difficult through the conventional methods.
Mm.
And after more than a year of being in the program and undergoing multiple rounds of testing, finally whole genome sequencing was done, which was not routinely available at the time. And in that, we found a very rare gene. There were maybe 10, 12 families reported total worldwide. And finally, we were able to give that family an answer. And I'm happy to say that recently they had another baby.
Mm.
Prenatal testing was done in the
Mm.
family, and this was a healthy baby.
Mm.
And they brought the child to the clinic. And it was very nice to see that the family finally is happy that they found an answer for their daughter also.
Mm.
And while they're doing the best that they can with her, but they also have a healthy child to look after now. So it's yeah, it's happy to see when the patients are satisfied. I think that's one of the most striking cases, because we've seen the years that that family struggled, but they never gave up. They would keep coming into the clinic once every few months to ask us if we had an answer. And I'm happy that finally we did, because in all rare diseases, you don't actually always get an answer. So
Yeah.
this was a good case.
Yeah. Right. And very encouraging.
Yes.
Uh, so my next question is that can you provide similarly an example of a rare disease case where genomic diagnosis was significantly influencing the management plan, including the treatment decision, prognosis, preventive measure, and how did it ultimately benefit the patient long-term health outcomes?
Right. So while this case, of course, focused mainly on the diagnostic part,
Mm.
the real advantage of the testing, obviously, is if we can even help the family with some kind of treatment option.
Mm.
So I would say that there are two limbs to this. We have two cases which are a place where genomic diagnosis helped in stopping unnecessary treatment. That is, that we had a patient who, at about 5, 6 months, went into rapid onset liver failure,
Mm.
and the family was considering doing a liver transplant. Now, a transplant is a very big surgery. You need a donor. So it's not just the patient, but also a healthy person has to undergo a surgery.
Mm.
And we did a very rapid genomic testing for this patient and did the result in about 5, 7 days, because the time was so critical. And at that time, rapid testing was not so commonly available. And we found a disorder that actually corrects itself in a few months' time.
Mm.
So we advised the family not to undergo transplant at that time. And it was a transient disorder. It looks very severe when it happens, but most of the children recover from it completely without needing transplant. So
Mm.
ultimately, that child recovered and didn't need transplant, which
Mm.
wouldn't have happened if they had not found the cause. Because for unexplained liver failure at such a young age, that to save the life, you have to do a transplant. Similarly, we had one more patient who was about to go a transplant, and we were able to do a genomic diagnosis for a different disorder and found out that in this case, the transplant is actually not going to be that effective. So
Mm.
then they chose to delay that, and then they explored the alternate treatment options. On the other hand, there are some patients we have where finding a diagnosis in time actually helps them in getting the treatment rather than avoiding unnecessary treatment. So there are some patients we have of spinal muscular atrophy, and the drug that is given, which is the gene therapy for this,
Mm,
is given within the first 2 years of life. So
mm,
we have multiple children that were diagnosed within the first 6 months to 12 months.
mm,
And by applying for compassionate access to the company who was providing it at the time,
mm,
many of them actually got gene therapy mainly because they had a genomic diagnosis.
mm,
Similarly, there was one patient, actually, again, a very rare case, and she was about 8, 9 months old baby, and people were absolutely not able to figure out what is wrong, and she was deteriorating at a very rapid pace. The family had already got the genetic testing done. They were from Rajasthan and they had come to Delhi for further opinion, but they didn't find a diagnosis. Genetic testing didn't give an answer. And then we went through the whole report, reanalyzed it, saw the patient's MRI, did a lot of work for her, and then we found the diagnosis. Now, the diagnosis that we found, actually, not only was it a rare disease, but also it can be severe. But then, to help the family, we found a clinical trial which was happening at the
mm,
time where
mm,
they were recruiting these children. So
mm,
we connected the family to the place where the trial is happening, shared the reports, took their opinion, and the family was given the option then to travel there. The trial people look after the families also when they travel for these cases.
mm,
So, for a disorder that can be nearly fatal, there was actually a ray of hope, because from that genetic test, we were able to get a report and confirm the diagnosis for that girl, and then send her off for some trial. If they were able to participate, then yes, that is the only ray of hope for that child. Otherwise, it's not possible. A few more disorders that there is actually some treatment available is, there is early bone marrow transplant available for some cases, such as metachromatic leukodystrophy, Krabbe disease, X-linked ALD. These are all rare disorders, but fortunately, if you do a hematopoietic stem cell or a bone marrow transplant very early in life before the damage starts, then it's actually curative for these patients.
mm,
And the only way to really get an answer very quickly is if you do the genomic testing early. But unfortunately, in India, like newborn screening or any kind of early testing is not really happening for such rare conditions. But if and when that starts, then many of these children will actually benefit very well, because the sooner we give the treatment to them, the sooner they will recover from this. Yeah.
right, right. And since we know that definitely rare diseases are being unraveled with the help of genomic testing, so what do you think that policies can be made which can enhance and support integrating genomic technologies for the diagnosis and management of rare diseases in India?
Yeah, absolutely. I think we're talking on a personal level, but policies definitely need to come into place. Like I said, the awareness for rare diseases has really increased, and largely a part of that is also because of the national policy for rare diseases that was released in 2021, the updated version. Disorders are an actual part of our country's healthcare problem and that they need to be addressed. So, the policy at present does outline some of the groups that they give treatment to,
Mm,
and they do identify some certain centers of excellence as well as Nidan Kendra where testing is a part of it. But unfortunately, the real life scenario is that the genomic testing is not very easily available, and it's actually outsourced mostly because even the centers don't have the facility for this testing.
mm,
So it is costly testing that is a problem. But I think, like we are suggesting for so many other spheres, that India needs to come up with some indigenous solutions.
mm,
So one is that the country should definitely try and focus on making the same equipment maybe at lower cost and providing the test at lower cost. The government can probably team up in a public private partnership and get the tests at a subsidized rate for the patients. Some of the centers of excellence and research facilities have the test machines, but they are utilized mainly for research purposes currently. I'm sure some of the centers can utilize these machines if the rare disease policy allows them to, which would really be a boon, because right now we have patients who are waiting months and months for test results and they're losing out on time for treatment in doing all this.
mm,
So, whether the policy ultimately allows for these partnerships, or at least allows for the use of the research facilities to also help the patients, that would really be a boon, because right now we are completely reliant on the private setups to do the testing. But definitely India has the resources, India has the brains to do all of this. We can try that. We have India made solutions, and there are some provisions that for the medicines as well, along with the testing, if like local Indian solutions can be made. So it would be lovely if even the testing can be enrolled into that, and for as many diseases as possible, if we are able to get the test as well as get the medicine made in India, I think that's the dream we are all working towards.
Right, right. And on this note, I would like to conclude. And I know that genomics is definitely opening new doors for the rare diseases for diagnosing, and by integrating these tests into the diagnostic and the treatment management part, we can definitely have a brighter future for rare disease patients. Thank
Absolutely.
you so much.
Thank you so much. It was lovely speaking with you.